Imagine this scenario. Someone you care about needs a life-saving organ, desperately. The clock's ticking. And then the doctors say, we found a potential donor. But what really happens next in those absolutely critical hours, maybe even minutes, before that organ gets the green light? It's a lot more complex than just matching blood types, isn't it? What actually determines if one person's body will, accept this vital part from another, or if it'll turn on it instantly? Today, we're doing a deep dive into exactly that, cross-matching in kidney and liver transplantation. Our mission, really, is to crack the code on these microscopic battles. We want to show you how doctors navigate this high-stakes immunological minefield to save lives. We'll unpack these critical, often invisible tests that determine compatibility, and explore why they're absolutely vital for kidneys, preventing immediate disaster, but surprisingly, maybe less critical for livers. It's a fascinating look at biological acceptance and rejection.
That's exactly right. It's almost like a preemptive strike in a way. It's all about assessing the immunological risk, for every potential donor-recipient pair and deciding, are they truly compatible? Or do we need some serious interventions first? The stakes, like you said, they just couldn't be higher because the specific problem cross-matching tackles is preventing this catastrophic thing called hyperacute rejection, which is just an instant, violent immune attack on the new organ.
Okay, so let's break down this crucial first step then. What exactly is cross-matching, like in simple terms?
Right. So at its core, cross-matching is a lab test done before the transplant. Its main job is to check if the recipient, the person getting the organ, has antibodies already in their blood. Antibodies that might target the potential donor cells. Think of it like a rapid security check. We take a little bit of the recipient's blood serum, that's the liquid part with the antibodies, and we mix it with cells from the donor, lymphocytes usually. Then we basically watch, do those antibodies latch onto the donor cells? Do they cause damage? The whole point, the number one goal, is to prevent that hyperacute rejection, that immediate devastating attack we mentioned. If that happens, the graft fails instantly.
So if that security check flags something,
Yeah.
if it comes back positive versus negative, what does that actually mean for the patient waiting?
Okay, so a positive cross-match means we found them. We found those donor-specific antibodies, DSAs, and that's basically a huge red flag. It signals a really high risk of immediate graft failure. On the other hand, a negative cross-match. Well, that means we didn't find those specific harmful antibodies. So it's more like a green light. It suggests a much safer immunological match, at least initially.
It sounds kind of similar to avoiding a bad blood transfusion, right?
Really?
We're giving A-type blood to a B-type person causes this immediate terrible reaction because of existing antibodies. Is that a fair comparison?
Absolutely. That's a great analogy. It's the same fundamental idea. You're trying to avoid an immediate clash because of pre-existing immunity. Just like you wouldn't give incompatible blood types, you really want to avoid transplanting an organ if the body is already primed to attack it immediately. The principle is the same, but the stakes with an organ even higher.
Okay, so given how vital this step is, how do the labs actually do it? Is it just one test, or are there different approaches?
Well, there are two main techniques, really, and they each give us slightly different information. The classic method, the one that's been around since the 1960s, thanks to Terasaki, is the complement-dependent cytotoxicity crossmatch. We usually just call it the CDC crossmatch.
The CDC crossmatch. Okay, how does that one work? What's the magic there?
It's pretty clever, actually. You take donor white blood cells, lymphocytes, and you incubate them with the recipient's serum. If the recipient has antibodies against those donor cells, the antibodies will bind, stick right onto them. Then comes the key ingredient, complement. Think of complement as like a demolition crew that gets activated by certain antibodies. If the antibodies have bound and they can activate this complement system, it triggers this whole cascade that ends up punching holes in the donor cells. They lyse or burst. We then add special dyes that only get into dead cells. So if we see a lot of dyed cells, say more than 20% are killed, that's a positive CDC crossmatch.
Ah, okay. So it's specifically looking for antibodies that can call in that demolition crew and actually kill the donor cells right there in the tube.
Exactly. That's its strength. It primarily detects the types of antibodies, usually IgG or IgM, that are really good at activating complement. These are the ones strongly linked to causing that immediate hyperacute or very rapid accelerated rejection. They're the most dangerous immediate threats.
Makes sense. But I assume, like most tests, it's not foolproof. Does the CDC crossmatch have downsides? limitations.
It does, yeah. While it's specific for those really dangerous antibodies, it's not the most sensitive test. It might miss antibodies that are present at lower levels or antibodies that don't happen to activate complement very well in that test system. So you could potentially get a false negative. The test says negative, but there are still some antibodies there. And sometimes, though less common now, you can get false positives from things like IgM autoantibodies. Labs have ways to deal with that, like using DTT to break down IgM or running an autocross-match to check for self-reactivity. But sensitivity is the main limitation.
Right. So if the CDC test might miss things, what
Mhm.
came next? What allows labs to get a more sensitive look to maybe catch those lower-level antibodies?
That brings us to the other major technique, the flow cytometry crossmatch, or FCXM. This one uses a different, much more sensitive technology. Again, you mix donor lymphocytes with the recipient's serum. Antibodies bind if they're specific, but instead of adding complement to see if cells die, you add a second set of antibodies. These are fluorescently labeled anti-human antibodies. They'll stick to any recipient antibodies that have already bound to the donor cells.
So it's not looking for cell death, just presence. Just seeing if any recipient antibodies are sticking to the donor cells, even if they aren't killing them in the tube.
Precisely. It uses a flow cytometer, which is basically a sophisticated machine that uses lasers to detect that fluorescence on individual cells. If the donor cells let up significantly more after incubation with the recipient serum compared to a control, that indicates antibody binding, and it's called a positive FCXM. Its big advantage is sensitivity. It can detect much lower levels of DSAs than CDC, and it doesn't rely on complement activation, so it can pick up antibodies that the CDC test might miss entirely.
That sounds like a huge plus. More information is usually better, right? Or is there a catch? Can it be too sensitive?
That's exactly the potential downside. Because it's so sensitive, it can sometimes detect antibodies that aren't actually causing significant harm in the patient. They might not be pathogenic, so you might get a positive result that doesn't necessarily predict a bad outcome. Leads to, well, potential false alarms or results that are harder to interpret clinically. The link between a positive FCXM, especially a weakly positive one, and actual graft problems is sometimes less clear-cut than with a positive CDC, which is why many labs today actually run both tests. The CDC gives you that strong signal for the really dangerous complement-fixing antibodies, and the FCXM gives you that high sensitivity to pick up almost any binding, even subtle reactions. You interpret them together.
Interesting. And when they do these tests, I understand they don't just test against a mix of donor cells. They often look at T cells and B cells separately. Why make that distinction? What do T cells versus B cells tell you?
Ah, yes, that's another layer of detail that's really important for interpretation. It helps us figure out what kind of HLA the antibodies are targeting. Let's start with the T cell crossmatch. Donor T lymphocytes primarily express HLA class I antigens. Think of HLA class I like HLA-A, BAS-B, C as one set of identification flags on the cell surface.
Okay, so if the recipient has antibodies that attack those class I flags on the donor's T cells, what's the significance?
A positive T-cell crossmatch, especially a positive CDC T-cell crossmatch, is a major red flag, like sirens going off. It tells you the recipient has antibodies against the donor's HLA class I antigens. And these anti-class I antibodies, particularly the complement-fixing ones detected by CDC, are strongly associated with causing immediate severe damage to the graft vessels. In kidney transplants, a positive T-cell CDC crossmatch is considered highly predictive of hyperacute rejection. It's generally seen as an absolute no-go for the transplant. Now compare that to the B-cell crossmatch. Donor B lymphocytes are a bit different. They express both HLA class I antigens and another set of flags called HLA class II antigens, like HLA-DR-DQ-DTP.
Ah, so B cells have both class I and class II flags, while T cells mostly just have class I. What does that mean for the test result? What if the B cell test is positive, but the T cell test was negative?
Exactly. If you get a positive B-cell crossmatch, but the T-cell crossmatch was negative, it often implies that the antibodies detected are primarily targeting the donor's HLA class II antigens, because those class II flags are on the B cells, but generally not on the resting T cells used in the test. Now, the clinical meaning of a positive B cell crossmatch is, well, it's more nuanced than a positive T cell crossmatch. Historically, a positive B cell CDC crossmatch with a negative T cell was seen as a risk factor, maybe linked to earlier rejection or slightly lower long-term graft survival, but usually not that immediate hyperacute rejection. Some positive B cell results can be due to weaker antibodies, non-complement fixing ones, or even those IgM autoantibodies we mentioned. Nowadays, if the B cell crossmatch is positive, especially by flow cytometry, clinicians will look very closely at the DSA profile from those Luminex tests we'll talk about later. A strong positive B-cell flow crossmatch that clearly matches up with known high-level anti-class II DSAs is definitely considered a significant risk factor for antibody-mediated rejection, even if it's not immediate hyperacute.
Okay, so putting it all together, T-cell crossmatches, particularly CDC T-cell, flag the most immediate acute danger, primarily from anti-class I antibodies,
Right, they're the absolute stop sign for kidney transplants.
while B-cell crossmatches cast a wider net, potentially picking up anti-class II antibodies, which are still risky, but maybe in a slightly different way.
You've got it. The T-cell crossmatch gives you specificity for that immediate threat. The B-cell crossmatch adds sensitivity, especially for class 2. The CDC T-cell is the gold standard for ruling out hyperacute rejection in kidneys. A positive result there. There's usually an absolute contraindication. The flow B-cell is probably the most sensitive overall, but you really need to interpret it in context with DSA info and the clinical picture. It's about combining all the pieces.
Let's really nail this down for the kidney. What does all this mean, practically speaking, for someone needing a kidney transplant?
For kidney transplants, the implications are stark. A positive crossmatch, and again, especially that positive T-cell CDC crossmatch, has traditionally been an absolute contraindication. Full stop. The risk of hyperacute rejection is just too high. The organ would likely fail immediately. And honestly, the routine use of pre-transplant cross-matching is why classic immediate hyperacute rejection of kidney grafts due to preformed DSAs is incredibly rare now. It's been virtually eliminated. If a potential kidney donor's cells are mixed with the recipient's serum and those T cells get killed in the CDC test, that transplant is usually aborted right there. Alternative donors or strategies are needed.
So conversely, a negative cross-match is basically the required green light for a standard kidney transplant.
It's a critical prerequisite, yes. A negative crossmatch, particularly a negative CDC crossmatch, is a very strong green light. It tells us there are no detectable preformed anti-donor antibodies of the type likely to cause immediate destruction. It virtually guarantees no hyperacute rejection. Now, that doesn't mean zero risk down the line, of course. Other types of rejection can happen later, or the patient might develop new antibodies after the transplant. But historically and currently, receiving a kidney transplant with a negative crossmatch leads to far, far better early outcomes. Markedly reduced chance of early antibody problems.
And we should probably just quickly remind listeners again about the other big compatibility hurdle for kidneys, ABO blood group, right? That's non-negotiable too, usually.
Absolutely. ABO incompatibility is just like a positive crossmatch in terms of risk for hyperacute rejection in kidneys. Needs to be compatible, unless specific desensitization protocols are used, which carry their own risks. And even beyond avoiding that immediate catastrophe, even if the CDC crossmatch is negative, but the more sensitive flow cytometry crossmatch is positive, that's still taken very seriously in kidney transplantation. It suggests the presence of DSAs, even if they're lower level or non-complement fixing. Many centers will avoid using that donor, or if they have to, like for a highly sensitized patient with few options, they'll use specific treatments like plasmapheresis, IVIG, or drugs to target B cells, trying to reduce that antibody risk. Because even those flow-only detectable DSAs are linked to higher rates of later antibody-mediated rejection, AMR, and chronic rejection, potentially shortening how long the kidney lasts. So the bottom line for kidneys: positive crossmatch generally means avoid, negative crossmatch is required, and predicts a much safer start.
Okay, now for the twist. This is where it gets really interesting, I think. You'd assume these life or death rules apply to all organs. But the liver, it just plays by different rules, doesn't it?
It really does. It's quite a contrast. In liver transplantation, the significance of these HLA crossmatch results is markedly different, to the point where many transplant centers don't even routinely perform HLA crossmatch testing before every liver transplant.
Wait, really? They just don't do it sometimes?
Yeah.
How can that be safe after everything we just said about kidneys?
It sounds counterintuitive, I know, but the reason is that hyperacute antibody-mediated rejection, that immediate destruction we fear in kidneys, is exceedingly rare in liver transplants, especially if they're ABO compatible.
So a positive crossmatch for a liver recipient is not the same immediate red light it is for a kidney.
Generally, no. It absolutely does not carry the same dire prognosis. There's tons of clinical experience showing successful liver transplants happening even across positive HLA cross-matches, where preformed DSAs were present. The liver itself seems to have this quality often described as immunologically privileged.
Immunologically privileged, what does that mean?
Well, it seems the liver has intrinsic mechanisms that help it tolerate or even mitigate antibody attack. It's a large organ. It has a huge population of resident immune cells called Kupffer cells within its structure. These cells, along with the liver's sheer size and blood flow, might help to absorb or clear circulating antibodies, sequester immune complexes, basically dampen the immune response locally. It contributes to a state of relative immune tolerance compared to the kidney.
That's incredible. So the organ itself fights back in a way, or at least absorbs the hit better?
Right. Something like that, yes. It's a fascinating area of biology. And because of this, historically, most liver transplant programs haven't considered a positive HLA crossmatch an absolute contraindication. The primary focus has always been on ABO compatibility. ABO incompatible liver transplant still carries a high risk of rejection, similar to kidney, but HLA compatibility has been seen as less critical for immediate survival.
But I think you mentioned earlier, things are maybe shifting a bit. Even for the forgiving liver, people are looking more closely at DSAs now.
That's right. The picture is becoming more nuanced. While classic hyperacute rejection is rare, there's emerging evidence, quite a bit of it now, showing that high levels of DSAs, especially strong antibodies against HLA class II, can be associated with increased risks in liver recipients. Not necessarily immediate failure, but maybe higher rates of acute rejection episodes, earlier development of fibrosis in the graft, or even vascular complications like hepatic artery thrombosis.
And what about antibody-mediated rejection, AMR, in the liver? You said it's rare, but does it happen?
It does. Acute AMR of the liver, which people used to think barely existed, is now a recognized, though still uncommon, clinical entity. It typically happens in patients with very potent DSAs. There are diagnostic criteria now involving biopsy findings like endothelial injury and C480 complement deposition in the liver tissue alongside detecting high levels of DSAs in the blood.
So how does this change practice? If surgeons find high DSAs in a liver candidate, do they still go ahead? Or do they maybe adjust the treatment?
It's leading to adjustments, yes. For liver candidates known to have high-strength DSAs, maybe based on those Luminex tests showing high MFI values, especially for class II. Some centers might choose to augment the standard immunosuppression. They might give IVIG or rituximab to deplete B cells or just monitor the patient much more closely after transplant for any signs of trouble. There's definitely a trend towards more routine DSA screening for liver patients, both before and after the transplant, even if a positive crossmatch itself isn't an absolute barrier. So, summing up the liver, a positive crossmatch isn't an automatic deal breaker like in kidneys. Livers often get transplanted despite preformed antibodies, and immediate outcomes can still be good. While negative is always preferred, the urgency and scarcity often mean surgeons won't turn down a suitable liver solely based on an HLA crossmatch. It's more of a risk factor that informs post-op management.
We've been throwing around this term DSAs, donor-specific antibodies, quite a bit. Let's just quickly recap what they are and how we actually find them so precisely these days.
Right. DSAs are just what they sound like. Antibodies in the recipient's blood that specifically target antigens, molecular flags, present on the donor cells, but not the recipient's own cells. Primarily, we're talking about antibodies against the donor's HLA molecules. And they usually develop because the recipient's immune system has encountered foreign HLA before through sensitizing events like blood transfusions, a previous transplant, or pregnancy.
And finding them used to rely just on that basic CDC crossmatch, right? How has it evolved?
It's evolved massively. We went from the CDC crossmatch, which just tells you yes or no, to cell killing, to panel reactive antibody or PRA testing, where you test the recipient's serum against a whole panel of cells from different people to get a percentage of how widely reactive they are. But the biggest leap has been the move to modern solid phase assays.
Like that Luminex test you mentioned, the single antigen bead assay, SAB.
Exactly, the Luminex SAB assay. That's been the real game changer. It uses these tiny microscopic beads, and each bead is coated with just one specific known HLA protein. You mix a patient's serum with a whole panel of these different beads. If the patient has an antibody against, say, HLA-A2, it will bind specifically to the beads coated with HLA-A2. Then you add a fluorescent anti-human IgG antibody and run it through the Luminex machine, which is similar to a flow cytometer. It tells you exactly which HLA specificities the patient has antibodies against, and it gives you a measure of how strong that antibody binding is, the mean fluorescence intensity, or MFI. It's incredibly sensitive and specific compared to the older methods.
Wow, okay. So you get this super detailed map of the patient's antibody profile, and that allows for the virtual crossmatch. How does that work? It sounds futuristic.
It's pretty amazing, and it's standard practice now. Once you have the donor's high-resolution HLA typing, which we get routinely now, and the recipient's detailed antibody profile from the SAB assay, you can basically compare them using computer software. The software checks. Does the recipient have any antibodies on their list that match the HLA antigens on the donor's list? If there's a match, the virtual cross-match is predicted to be positive. If there are no matching antibodies against the donor's HLA, it's predicted negative. This is hugely powerful for organ allocation, especially for highly sensitized patients who have antibodies against many different HLAs. It allows centers to screen potential donors electronically before the organ is even offered or shipped, avoiding sending organs that would just be incompatible anyway. Saves precious time and resources. We even calculate a CPRA, or calculated PRA, based on the antibody profile, predicting what percentage of donors would be incompatible.
So it's shifted from just, do you have antibodies, to which specific antibodies do you have and how strong are they?
Precisely. And that leads to the understanding that not all DSAs are created equal. An antibody with a very high MFI value is generally considered higher risk than one with a low MFI. And we're also learning more about the importance of which subclass of IgG the antibody is, and critically, whether it can activate complement. There are newer assays that specifically test for complement activation potential, like C1q or C3d binding assays on those Luminex beads. Antibodies that strongly bind complement are generally associated with worse outcomes, more rejection.
And you mentioned for livers, sometimes these DSAs just disappear after transplant.
Yeah, that's one of the intriguing things about the liver's tolerance. Preformed DSAs, especially lower-level ones, can sometimes become undetectable in the blood shortly after a liver transplant. However, if DSAs persist long-term, or if the patient develops new DSAs after the transplant, we call those de novo DSAs, that is considered a risk factor for chronic rejection or other late complications in the liver, just like in the kidney. It's still a very active area of research, figuring out exactly which DSAs matter most in the liver long-term. But overall, yes, detecting and characterizing DSAs before transplants, especially for kidneys, is absolutely crucial now. These modern tools let us make much more informed decisions.
This field is clearly moving fast. What's next? What's on the horizon for cross-matching and compatibility testing?
Well, the virtual crossmatch is already here and is becoming more central. Improving its accuracy, especially dealing with rare HLA types or ambiguities in testing, is ongoing work. Its speed is a massive advantage. Then there's that enhanced antibody characterization we just talked about, really digging into which DSAs are dangerous. Those C1q-C3 binding assays, looking at IgG subclasses, that's helping refine risk assessment.
Are there other types of antibodies beyond HLA that people are starting to look at?
Yes, definitely. While HLA is the main player, we know other antibodies can cause rejection. Antibodies against targets like MICA and MICB, or even non-HLA targets like the AT1 receptor on endothelial cells, are implicated in some rejection cases. So there's research into developing reliable cross-match assays for these non-HLA antibodies too, like experimental endothelial cell cross-matches. It's complex, though, and I mentioned solid-phase cross-matching earlier using beads coated with the donor's actual HLA profile. That's conceptually neat, combining specificity with the direct test, but it hasn't really taken off widely yet. Probably the biggest excitement is around combining next-generation sequencing for ultra-precise HLA typing with computational approaches like epitope matching.
Epitope matching,
Yeah.
what's that?
Instead of just looking at whole HLA antigens, like HLA-A2, epitope matching looks at the specific small regions, the actual amino acid differences on the HLA molecule that antibodies recognize. By understanding which specific epitopes a patient has antibodies against and which epitopes are on the donor's HLA, we can potentially identify acceptable mismatches. These would be donors who are technically HLA mismatched, but the specific mismatch parts aren't targeted by the recipient's antibodies. This could hugely expand the donor pool for highly sensitized patients. Tools like HLA Matchmaker are exploring this.
And any push towards making the tests themselves faster or easier?
Absolutely. Automation is always a goal, to improve consistency and speed up readings. And the dream for some situations, like maybe deceased donor transplants where time is critical, is a reliable, rapid, point-of-care cross-match kit, something you could potentially even use near the operating room. That's still a way off for routine use, but people are working on it. So yeah, cross-matching started simply with watching cells die in a tube, and now it's evolved into this incredibly sophisticated field. The trend is definitely towards more precision, more speed, and ultimately safer transplants for more people.
Okay, so wrapping this all up, what's the big takeaway for you, the listener, from this deep dive into the complex world of cross-matching?
I think the fundamental takeaway is that stark difference we kept highlighting. Kidneys really live or die by the results of the crossmatch, especially that classic CDC test for hyperacute rejection, whereas livers, due to their remarkable immunological resilience, their immune privilege, are just much more forgiving of pre-existing HLA antibodies. It really underscores how different organs interact with the immune system.
It really does. And it makes you think about that delicate balancing act happening constantly in transplant medicine, doesn't it? Weighing the immunological risk against the urgency of the need, using these incredibly precise scientific tools to make life or death decisions in real time. The future clearly promises even more personalized approaches, tailoring compatibility assessment right down to the molecular level. But ultimately, as you listen, consider that it'll always come down to that fundamental challenge: balancing the speed needed to save a life with the safety required to make that new life last, and finding that just right match in a sea of biological complexity.